Okay, so hello everyone. Our guest speakers today are Brandon Gaudiano and Ethan Moitra from Brown University in the United States. I'll give you a quick description of their work, but they'll tell you much more about their activities in a moment. So Brandon, our first speaker, I suppose they'll combine they'll divide and conquer. Brandon holds a joint academic appointment as a professor in the Department of Psychiatry and Human Behavior and in the Department of Behavioral and Social Sciences at Brown University. He's the director of the Transitional Outpatient Program and associate director of the Psychosocial Research Program at the affiliated Butler Hospital. He is a research psychologist at the Providence VA Medical Center and primary faculty at the Mindfulness Center at Brown University. So Brandon, I've known Brandon for years and Ethan as well, and collaborated with both of them. We've had a lot of good and interesting projects together. Brandon's published over 200 articles and other works. He published a book on suicide prevention that was published by Oxford University Press in 2022. His main interests involve cognitive, behavioral, and acceptance and mindfulness-based therapies, digital and mobile health technologies, which you'll hear more about in a moment, and dissemination and implementation in mental health. Ethan Moitra. So Ethan is an associate professor in the Department of Psychiatry and Human Behavior at Brown University. He's a faculty member at the Providence Boston Center for AIDS Research, primary faculty member at the Mindfulness Center at Brown as well. His work focuses on the effects of affective symptoms and functioning and self-care. This includes adherence and behaviors and treatment, examining the interaction of anxiety and mood disorders with medical illnesses, particularly HIV, and translating these findings into innovative treatments. This, of course, involves leveraging technology, implementing these interventions in non-traditional settings at important transitional periods. And so by transitional periods, we're talking about the journey of people through the mental health care system, right? In and out of hospitalizations and various levels of intensity of mental health services. So they've both received more awards and grants than we have time to describe here, but they've been very productive and very successful in grant acquisition and in other domains. So thanks very much, Ethan and Brandon, for giving us the talk today, and we will hand it over to you.
All right, well, great. Thank you all for being here. So appreciative of this opportunity. I didn't realize it was a holiday in Ghana, so thank you all from Ghana for joining us. I know it's getting close to dinner time too, so we won't keep you on too late, but happy to have you all here and thank you for this opportunity. I'm going to share my slides, and just as you said, Dror, Brandon and I are going to sort of take turns going through these together. So and much of our work, I'm just going to skip right past that. Much of our work has been funded by the federal government, mostly the National Institute of Health. And a lot of this work has occurred here in Providence, Rhode Island, especially at Butler Hospital, which is our primary adult psychiatric facility here in our area. And so here's a list of all our studies. We're going to get into some of the details of these as we go forward. And just a brief outline. So I'm going to start with just a background about our sort of thought process of why we're focusing on what we do in our work and the importance of it, I think I'll hope to convey. Brandon's going to talk a little bit about therapist-delivered interventions. I'm going to talk a little more about technology, and then we're going to wrap up with some future directions and hopefully have some time for some questions and discussion. So serious mental illness, SMI, I think probably many of you know this, but just to be clear, when we use SMI, we're referring to people with bipolar disorder, major depression, schizophrenia or schizophrenia spectrum disorders, these other severe disorders. We know that worldwide, these conditions affect over 400 million people and really take their toll in so many different ways in terms of functional impairments, in terms of risk of suicide, in terms of just chronic symptoms that are difficult to treat and manage. And as Dror alluded to, what we're really going to focus on is transitions of care. And for us, that really means the transition from acute care, which we think of as psychiatric inpatient hospitalization. Also here at Butler, we have intensive outpatient programs, or what we describe as partial hospitalization programs. So patients do not spend the night here at the hospital, but they will come in early in the morning and spend a full day here doing groups and individual therapies and meeting with medication providers, and then go home in the evening. And so these acute care environments and structures that then at some point will lead to a discharge back into the community, back into outpatient services and outpatient providers. And we've been really interested in this transitional period, I think especially that first month after leaving acute care, because of all of the risks and all the challenges that occurred during that period. We know when people are in acute care, they're working on being stabilized and under, careful attention from providers. They get discharged, usually with a discharge plan, which outlines their medications, their appointments. Usually they're scheduled to at least see a provider or two right away as soon as they leave the hospital. And then they go out to outpatient care. But we know that a lot of people don't follow through with that discharge plan. We also know that first month, especially after people leave the hospital, there's a high risk of rehospitalization. Some studies show at least up to 30% or more of patients that are discharged are back in the hospital here in the US, at least within a month. And to us, that feels like a problem on so many levels. Certainly for the patient, we recognize that hospitalization, whether it's inpatient or intensive programs, can really disrupt lives and take people out of their natural home environments. From the provider perspective, really, especially here in Rhode Island, we're feeling a shortage of mental health providers, and we feel the strain on the system when patients are coming and we have limited beds here at the hospital. And also from a broader financial perspective, we believe that so many healthcare dollars are wasted when people just come in and out in this revolving door sort of way from the hospital. And so that's part of sort of where we first started really thinking about these issues, was recognizing there's something going on here and we need to do something about it. On this slide, you see just a little more to add to my point, especially suicide. You're going to hear a lot about suicide as we talk today. That first month after people leave an acute care setting, they're at very high risk of suicide. And really for the year after leaving an acute care setting, the risk of suicide is 30 to 60 times higher than it is for stable community patients. And the reason we talk so much about suicide today is it's the leading cause of death for people in the US with SMI. We also know that treatment non-adherence plays a big role in these challenges when people leave the acute care setting. And that's non-adherence meaning people not taking their medication, people not attending those outpatient appointments that have been scheduled for them. And so they really leave the hospital sort of on their own. And some people follow through with the plan and get connected or reconnected in all the good ways that we would want, but a lot of people don't. And so this next slide really just lists sort of our key questions that we've been grappling with and thinking through as we've approached our research studies and our clinical programs. First of all, who is responsible for the patient after they leave the hospital? Well, here at Butler, here in Rhode Island, we have great clinicians at the hospital who are well-intentioned and caring and certainly want the best for their patients, but as soon as a patient leaves, they're bringing somebody else new into the hospital and into that bed. And so they don't necessarily have the time or availability to really pay attention to what's happened to that person who just left. On the outpatient provider side, we're also seeing challenges. So for instance, often patients will be scheduled with providers who they've never seen before, say a counselor or therapist who they've never met before, and an appointment is made, but that provider doesn't really know the patient. They don't know what's going on. They don't know what the issues may be, and they don't necessarily have the time or knowledge to really inform outreach to ensure that person's going to show up at that appointment next week or whatever it might be. And so this has really led to the second big theme of questioning that we have, which is how are these transitions in care coordinated among the acute care and the outpatient providers? It's really challenging, and it doesn't happen a lot. And of course, then this leads to this challenge. Well, what if a patient does not adhere to their discharge plan? Where can we help? Where can we make a difference? How can we prevent that rehospitalization that may be coming, or something even worse like suicide? And so those are just some basic questions and sort of points that have really guided our work. So I'm going to turn now to Dr. Gaudiano, who's going to speak a little bit more about some of our therapist supported programs.
Great. Yeah, thanks, Ethan. Everybody hear me okay? That's good. Okay, good. And you're in control of the slides. You can, I'll let you know you can move forward. Thanks. As Ethan was saying, so what we wanted to do for this talk is just give you some examples of some various programs that fit in this transitions of care space to give you, some variety of kind of the work that we've been doing here locally. And we're really interested in sort of how this work might relate to some of the challenges and situations that you're facing locally yourself. But I'm going to start, as Ethan said, with the program that we have about suicide, and suicide has become an increasingly important focus, certainly here in the U.S., but worldwide. But it's the 11th leading cause of death in the U.S., second leading cause of death among 15 to 29-year-olds, and rates generally have been increasing over the recent decade or so. Next slide. And so really what this translates to is that one person dies by suicide worldwide about every 40 seconds. So, imagine the lives lost just, again, during this brief talk that we're going to do. So that's why we're focused on this issue. And as Ethan had mentioned, in particular, when people are leaving the hospital, that's a really very heightened risk for suicide. Next slide. So one of the programs that my colleagues and I developed here at Brown is called the CLASS program, the Coping Long-Term with Active Suicide program. And it was designed to try to address this problem and to specifically provide a service that hopefully would be helpful for people when they're transitioning from a higher to lower level of care and their suicide risk is elevated. And so we recently published, as you saw there, a book kind of detailing it. But I'll kind of give you a brief overview of it here. So, like I said, this was originally designed and we piloted, as you'll see in a moment, for patients who were here locally at our psychiatric hospital. And it has a few initial one-on-one sessions with the patient. We try to start during the hospitalization and then continue and follow up right after discharge, because that's really a time when people are at most risk. And then we also try to incorporate a family member or significant other into the intervention. So we have a family meeting after that when we can. And then the rest of the intervention is mostly brief follow-up phone or video contacts with the patient and their significant other or family member over the next 6 months, and it decreases in frequency over time. So this is meant to be an adjunct to their other primary treatment, not to replace it, but to provide an extra level of support and care during the difficult and challenging transition period. Next slide, thanks. In terms of the CLASS program, we really focus on a risk reduction model similar to other kind of management of chronic illnesses. And we're looking here to target what we might call malleable risk factors. So those things that we feel like we can change or that the intervention can have some positive impact on. One of those things is hopelessness. The next is social support, targeting isolation. A third one is problem solving and coping. And a fourth one is treatment engagement and treatment adherence. So the CLASP intervention really tries to focus on those because those are risk factors for suicide, generally speaking. In this population, we also incorporate more personalized individual risk factors that the person may have. So say they have drug or alcohol use problems or some other problem like psychosis or hallucinations or various psychotic symptoms that also might come into play when we're thinking about their suicide risk. Next slide. And it blends, this CLASP intervention blends a few different components to be something a little bit different than what's been out there before. So one is that it really focuses on the patient's personal values, and we get some of these components from acceptance and commitment therapy, if you're familiar with that kind of treatment. As I mentioned, we also try to incorporate family members and significant others into the intervention, and because we recognize how important and critical that is, so there's a family intervention component. There's more traditional cognitive behavioral problem-solving type components, and also recognizing that a lot of these patients are dealing with a lot of social determinants of health issues. There are case management elements as well. Next slide, thanks. So this is just sort of an example of then how we sort of use the components of the intervention to really target these risk factors. So values for hopelessness, family for the isolation piece, problem solving for the coping deficits that the patients might have. And then really all of these factors really are designed to be addressing any kind of treatment non-adherence or lack of engagement with their primary treatments. And like I said, this is an adjunctive intervention, so it's not meant to replace their primary medication prescriber or even their primary therapist or case manager or other services that they might be getting. And so to differentiate that, the way we look at CLASP is instead of identifying that person as a CLASP therapist or case manager, we really call them treatment advisors. And that's because they really are sort of serving a supplemental or augmented role in the person's overall care. So they're doing risk monitoring, facilitating values-based problem solving, fostering patient-family interactions, doing some case management, and then maybe there are some specific therapy techniques or counseling techniques that would be helpful in terms of symptom management, things of that nature that they also can provide. And so really what we like to say is that it's not exactly one of those things, but it's kind of a combination. So there's elements of family therapy, traditional psychotherapy, and case management, and those elements combine into this CLASP intervention that we developed. So let's just talk a little bit about some of the preliminary work we did to establish whether CLASP is effective. So we started with an open trial here conducted at Butler Hospital, and these were patients who were entered into the study who had a recent suicide attempt or active suicidal ideation with intent when they entered the hospital. They all had diagnoses of major depression, usually quite severe, and they often had a suicide attempt history. Over 60% had more than 3 attempts in their lifetime. So it's a very high-risk group. In general, we found that about 24% sort of dropped out initially, but the other group was retained. About 83% completed their in-person sessions, 96% completed their telephone calls, and about 79% of the family members also completed their contacts as well. So we had fairly good engagement.
Recording in progress.
Next, thank you. So in terms of, we looked out post-hospital discharge from the hospital about 6 months, and we found that no participant, fortunately, had died by suicide in the study. We did have 3 participants, about 12%, who made a non-fatal suicide attempt in that period, but that compared pretty well with what we would expect. So when we look in the literature, we would have expected about 15 to 25% suicide attempt rate. So we felt like we were in the right direction here in terms of maybe the potential impact of CLASP on reducing suicide risk. Next slide. So then we conducted a pilot randomized controlled trial. Again, in the same patient population, the same hospital. We either randomly assign them to this augmented CLASP intervention in addition to their treatment as usual that they were receiving, or a control condition where we provided them with enhanced assessment and follow-up evaluation, just not the actual CLASP element. So we still monitored risk and supported them in engaging with their care, but not as actively as we did in CLASP. And again, we looked at the sample up to 6 months. And generally what we found again was that we had about a 13% subsequent suicide attempt rate in the CLASP condition, and in the control condition, it was more like 23%. And if we look across both the open and the randomized trial, we see that those rates are lower than, again, either the control condition in the randomized trial or what we would generally expect in this population in other studies that have been reported. So we've since conducted some follow-up studies of CLASP to look at it in various settings. One of the ones that we did that I want to highlight is what's called our ED SAFE study. And ED SAFE at the time, a few years ago, was the largest suicide prevention trial ever conducted in the United States at the time. And it had 8 different sites across the country where we tested a modified version of CLASP. This time, we transported it from the psychiatric hospital setting to the emergency department setting, so in medical settings, for people who are identified at suicide risk entering or after emergency room visit. And then we tested out whether CLASP was effective for them in a more naturalistic study. And this used a non-randomized stepped wedge design of several phases, which I'll describe in a second. But in general, it was for 1,376 participants across all 3 phases. And thanks, you can go to the next slide now. So the first phase, we did nothing, so nothing was changed in the emergency department. The second phase, we initiated suicide screening, but no aftercare intervention post that. People were given standard referrals and things like that. And then in the third phase, we tested CLASP following discharge from the emergency department. And in general, we looked then over a 12-month period in terms of following the ED visit. And we found a significantly reduced risk in the third phase relative to the other 2 phases when we added in the CLASP intervention in terms of first overall deaths and suicide attempts, and then in the next slide, the average number of suicide attempts. And even though the effect was relatively small from a numerical standpoint, it really was quite significant in terms of the number of lives that when you scale this up and think about sort of actual lives saved by this type of intervention and what was provided. Next, thanks. And we also did a cost analysis of the intervention and finding that it was also beneficial from a cost perspective to provide CLASP relative to what it was able to prevent in avoidable deaths as part of the treatment. So just sort of a summary from here. Our CLASP intervention is adjunctive. It focuses on targeting multiple risk factors for suicide. It doesn't require intensive interventionist training, so it's meant to be provided by master's level counselors or others with similar types of experience with mental health patient populations. Relatively cost effective, and there is evidence to support that it does have direct effects on suicide attempts and other suicidal behaviors. And then I just want to highlight another program that's sort of another therapist-delivered aftercare program called our ITAP, or Integrated Treatment Adherence Program. And that is focused, has been traditionally focused on patients with bipolar and substance use problems. And that's because of a number of different things. So one is that those 2 problems tend to co-occur a lot. So people with bipolar disorder and substance use, about 60% have a substance use history. We also find that patients with bipolar disorder have high rates of treatment non-adherence, and that tends to be even more of a challenge when there's a substance use problem that's comorbid to the mood disorder. And of course, it's related to all these negative outcomes post-discharge, including suicide, relapse, rehospitalizations in those initial months. And there's really not a lot of specific programs designed for this population, and their needs are pretty unique because of both the mood management. Isn't muted. That's okay. In terms of the lack of intervention I was just mentioning, but you can go on to the next slide. So, and in these studies, we've kind of expanded our idea of sort of a transition of care event to be a little bit more inclusive. So we can look, of course, at the traditional inpatient to outpatient transition, but we could also think of that partial hospital period when they might not be living at the hospital or actually admitted to the hospital, but they might be doing a more intensive program, and then they're going to more long-term outpatient patient care. We could also look at times when they're accessing crisis services or urgent care services, or going to the emergency department, or even leaving a substance use treatment program. But all of these are sort of transitions of care where they're going from higher levels to lower levels, and that is a unique period of risk where we could think about like what would be needed to help that person to be more successful in that transition. And often it means that they need some extra elements than what they traditionally would be doing as part of just long-term outpatient care. In terms of our ITAP model, just sort of giving you some sense of what we're targeting here. Again, we're looking at, with this population, treatment non-adherence, suicidality, mood management, substance use, abstinence if that's their goal, or decreasing that use, social support elements like that. We are using, again, very similar strategies in terms of these are therapist-delivered adjunctive program, post-transition of care, when we are doing some extra follow-up and support with the patient in coordination with their treatment providers. And one of the things that we're targeting in these interventions is what we call values action consistency. So what we want to do is identify for the patient, what are their values, what's important to them, and how does that relate to their treatment engagement, both positively and negatively? So do they see an alignment between their personal values and what they are trying to achieve in their life and their treatment, or is there some disconnect there? And how can we try to help the person problem solve, address, and align those things better so that hopefully they would be more likely and willing and interested in engaging in treatment? And more importantly, too, that really that treatment is actually going to work better for them because it's going to better fit what their interests are. Or is there a conflict there that needs to be addressed or supported in some other way? So these are all things that we're trying to do with sort of this focus on treatment engagement. Next slide. So in terms of the way ITAP is approaching it, we really are looking at it as not just sort of these top-down recommendations about treatment in terms of what the patient is supposed to follow, because even if that might be objectively the best case scenario, it doesn't mean that that person is going to do it. So we really want to focus on this idea of a more collaborative, patient-centered approach to the shared decision-making in treatment. And that's part of what the ITAP program is designed to help that patient address. And like I mentioned earlier, that means trying to identify what their core values are, what's important to them, how that relates to the treatment that they're receiving, and how to help them to navigate and discuss any kinds of conflicts or issues with that with their primary treatment providers, and to support them in doing that. And again, we also try to have some family involvement when we can, because often the family is also a part of that, and that could be either because there's a conflict there, or it could be because that's a support person that we can leverage. One of the things that we do also is try to help to develop a plan that we call the life plan with the patient. And that's where, again, we're trying to link these personal value directions and life directions with the patient with the goals that they're trying to achieve post-transition of care, and then what the steps would be that would be necessary to achieve that. So again, we're trying to get these things in alignment. When they're not in alignment, we're trying to help the patient problem solve and work through any potential conflicts, and then help them to work with other providers to make everything mesh together in hopefully a better and more consistent way. So one of the initial projects we did for ITAP was a pilot randomized controlled trial, similar to the CLASP trial, where patients either received ITAP or an enhanced monitoring and assessment condition post-hospital discharge, and we looked over 6 months. And in terms of some of the outcomes we saw a positive effect on greater reduction for ITAP in the depressive symptoms. Looks like I lost one of my legends there, but that's okay. So the red line is the ITAP condition. So you can go on, Ethan, it's okay. Yeah, and then a further reduction in manic symptoms in the ITAP condition. Next slide. A better reduction in functional impairment over the 6 months. and an increase, which is sort of one of our theorized treatment mechanisms of values-consistent living in those who received ITAP. So, were they aligning their values more with their day-to-day actions and what was important to them? And also we looked at and we found some positive effects on their medication adherence rates over time, as well as those things kind of came into alignment. So right now we're testing out the ITAP intervention in a larger, broader scale studies. In fact, two different effectiveness implementation trials, one funded by the National Institute of Mental Health, the other by the Veterans Administration, Department of Veterans Affairs in the United States. And so one is done at a veterans hospital, the other is being done in a private civilian psychiatric hospital. And we're going to, look at these effects of ITAP for people leaving a transition of care with this comorbid mood disorder and substance use problem to see if we can identify how best to help them with their transition of care. And also, in particular, kind of what the implementation challenges might be to how we would implement this if it was found to be more broadly accepted. Okay, I think this is now turning back to you, Ethan, and you can kind of take over and then I'll join you later.
Yeah, sounds good. Thank you, Brandon. So now to turn to technology. So I'm going to review some studies that we've done over the last decade or so. And I know this is a technology-friendly audience, but I'll just share from our perspective. Of course, there's novelty and innovation when it comes to integrating digital whatever into clinical care and research. But we really see technology as important and promising because it can expand reach, it can potentially reduce costs, and can really connect with patients, especially in these transitional periods when we know that they aren't necessarily getting a lot of contact from providers. And so our work started over 10 years ago now with this MAP study. This was an assessment-only study funded by the National Institute of Mental Health. And over 10 years ago here in the US, although people were getting more and more smartphones, the literature showed that most adults with SMI did not have their own smartphones just yet. And so this little picture here on the screen is the Palm devices that we purchased as part of our study and gave to our participants. And I'm going to describe the basic kind of framework of the study, and it's one that we've used in various ways in the additional projects that I'll be talking about. And so what we did was we approached patients during their acute care, often inpatient hospitalizations here at Butler Hospital in Rhode Island, and screen them for psychotic spectrum disorders or SMI and these other details for eligibility. And if they enrolled in our study, what we would do is at the time of discharge, we would give them one of these devices. These devices were purchased by our study and programmed by us, just using a very simple sort of XML coding scheme to prompt people 3 times a day to answer questions about a variety of things that we thought would be relevant to their mental health, their stability, and certainly their functioning and treatment adherence. And so you see here in this one example, we always ask people, who's with you? Friends, family, strangers, nobody. We ask questions about mood, especially depression, anxiety, irritability, stresses, stressors that a certain stressful event occurs since the last time you answered a question, substance use, and also symptoms of psychosis. This was an assessment-only study using an ecological momentary assessment paradigm or EMA. And so for those who aren't familiar, EMA really is very popular these days. And I think it's just being used more and more for all sorts of reasons, especially in terms of research. And the rationale behind it is that asking somebody a question in their real world daily life in the moment is going to provide more ecologically valid information than if we were to ask those same questions retrospectively in our traditional sort of paper and pencil assessments that we often do in clinical and research work. And so rather than asking about how somebody's mood was over the past week or how many times they missed their medications since last time we saw them, we can actually use an electronic device like these old school palm devices to ask people about those same issues in the moment. This MAP study ultimately included 65 patients recruited here from Butler Hospital. And at discharge, they were given this device, which was programmed to collect all this information. And they were able to use it, and it was programmed to prompt them for up to 4 weeks after discharge. Again, coming back to what we've been talking about, I was saying earlier that first month in particular is this really high risk period for all these issues. And here are the main sort of findings and papers really that we've published from this work that I really want to highlight. And so again, 10 plus years ago, connectivity wasn't that great, especially in the SMI population here in the US. And so we wanted to start with just some foundational, fundamental questions like, are patients going to find this? Are they going to be receptive to it? Are they open to answering these questions? Generally, our results showed that yes, it's acceptable and they generally were positive. We also wanted to look at feasibility in terms of not just being able to recruit people from the hospital. That's challenging in itself. And for any of you who work on inpatient units, you know, people can be stable sometimes, not so stable other times. They can be busy with groups. They can be asleep. There are all sorts of things that can get in the way of recruitment on an inpatient unit, but also really, I think, speak to the challenges and the functional impairments that come with SMI. And so can we recruit people during this very difficult acute period? And can we actually get them to engage with a device and answer questions, you know, on this regular basis? So what we found in terms of feasibility is that on average, people completed about 28 to 31% of those assessments. And these assessments were set up to occur once in the morning, once in the afternoon, once in the evening. Now, I know when I was first learning about EMA and even kind of like seeing these kinds of numbers and thinking about it, it felt like 28 to 31%, like that seems so low, right? I mean, it seems really low in terms of everything we're offering. But what we always come back to and always kind of remind ourselves and remind others as we think about this work is that typically in outpatient care, maybe at most patients are seeing their providers once a week. For medication prescribers, sometimes it's more like once a month or once every few months. And so those outpatient providers are getting information from that day once a week and maybe some retrospective reporting. Here we are saying about a third of the assessments are completed for each week for 4 weeks. Well, that averages out to about once a day, maybe a little less. And so once a day, gathering information about how a person is doing is a lot more than what we're currently getting through our traditional outpatient assessments and clinical work. And so it is important, and getting once a day is meaningful, even though it doesn't look like a lot. We also looked at predictors of engagement with the EMA paradigm. We found that cannabis use predicted non-compliance or less use of it. Also, we found that by week 4, people were just answering less questions. The excitement, the interest, the sort of novelty of having this device asking things just was starting to kind of wear off. And I think for any of us who have tried different apps on our phones, that may feel familiar. You know, those initial weeks, it's kind of fun and exciting to do something new. Over time, especially getting asked the same questions 3 times a day for 4 weeks, you get a little tired of it. And so understandably, people's engagement decreased a bit. But still, we were pleased with those results and pleased to see that an EMA type approach, mobile device approach, was really viable in this population. We looked at predictors of non-adherence, and we say beliefs there in parentheses because we had trouble monitoring objectively people's medication adherence. And so we looked at it through EMA just based on essentially these questions that related to a person's willingness to take medication the next day. And what we found is that irritability, sadness, these other variables there predicted non-adherence or the likelihood of non-adherence the next day. So we also got some interesting information there. And lastly, we're wondering, and we continue to think about this, does EMA in this context with this population provide some added value? Meaning, is there something additional that we can learn by conducting these assessments in this way? Is there some information that we could gather that we would otherwise miss? And what we found, and this was comparing our EMA data to our traditional assessments, for instance, like we had patients in the study complete assessments at that 4-week mark at the end of the EMA period, retrospectively talking about the previous 4 weeks. And what we found was that our participants were more likely to report their substance use, their medication non-adherence, and psychotic symptoms through EMA versus those retrospective assessments. Now, the reasons behind that, who knows exactly? Is it recall bias? Is it that people are more willing to report substance use through a device versus telling somebody face-to-face? It could be all sorts of factors, but it really started to say, okay, we're onto something here, and these devices and this sort of approach can be used in this population in this difficult period, and there's some new and important information that can be gathered. So we built on the MAP study with our next project, which we completed a handful of years ago, called the MAX study, this mobile aftercare support program. We use that same EMA approach, 3 times a day, assessing all the variables I've described. And what we added to it was a just-in-time adaptive intervention protocol. And so for this one, we contracted with a vendor that sort of provided a platform for EMA-based studies, and we programmed our questions and details into it. What this just-in-time intervention means is that if somebody reported a certain thing through EMA, the device, the app, was programmed to then respond specifically to that issue. And so at this stage, we no longer use those Palm Pilots. We did rely on people's own devices. People's connectivity had increased, probably like 50, 60% at that point. So people were able to use their own smartphones. And if somebody reported something like medication non-adherence, then they would receive a question, okay, what were the reasons for that? Was it forgetfulness? Did you run out of medication? Is it side effect concerns? What might it be? And then the device and the app was programmed to respond in certain ways to support adherence. We also had related interventions that were driven by CBT and other evidence-based approaches to support down mood, psychotic symptoms, substance use, and other issues. We conducted the MAX study in these 3 phases. And so in the open trial, small group, just about 10 people, but consistently now we're seeing, again, the usability is there, the satisfaction is there. People are willing to engage with an app, especially if it's on their own device. It was an uncontrolled study, so who knows if this was exactly because of the intervention itself, but we found that dysfunctional coping strategies reduced, and that was in line with what we were trying to do. We were trying to improve healthier evidence-based coping strategies. We also found that psychiatric symptoms improved. Next, we moved on to a larger group, 42 people involved in a randomized controlled trial. So these are folks with SMI. We compared the MAX app to a comparison app that we also created, which essentially was designed to be time matched for attention and engagement to really control for the reactivity that comes with being asked questions about your mood and symptoms, multiple times a day. And so the comparison app had the same EMA questions: how are you feeling? Who's around you? What's been going on? Substance use, all that. And then instead of providing these evidence-based interventions for coping and adherence, instead what we provided was just some very simple psychoeducation related to SMI and the importance of medication and topics like that. And so those results were mixed. What we found ultimately, not necessarily in a bad way, but in terms of our MAX app, it didn't do any better than the comparison app. People in both conditions show these improved symptoms and reduced dysfunctional coping approaches. But we did find that there was more engagement with the MAX app compared to the psychoeducation comparison ones, 74% versus 43%. And lastly, in the MAX study, our third aspect was stakeholder and community partner interviews. And so we met with a variety of people who work with folks in the SMI world, both on the inpatient and outpatient side, so clinicians, administrators. We also met with support staff, so secretaries, administrative assistants who maybe don't provide clinical care, but certainly interact and engage with this population, and ask them questions about the issues related to the transition of care and also about their openness and thoughts around integrating technology into care, and what the concerns or challenges might be. As Brandon mentioned, we've always taken the angle that these approaches are adjunctive and add to what's out there. We're not trying to replace outpatient care, but we're trying to do something extra to help. And what we consistently heard from our stakeholders is there's an openness to technology, that of course adherence and discharge planning, all that is challenging. And one thing that really stood out, especially speaking to the administrators, was if we can show, or if one could show that an app is going to lead to these positive benefits, less symptoms, more adherence, less rehospitalizations even, those are the details that we need to be able to sell and get the funding for, sell this idea to our supervisors and get the funding and means to be able to actually deliver something like this into in our clinical space. And so lastly, then just briefly, I'm going to touch on our current study. This is the T-Focus study. It's taken everything we've learned from those initial studies. Here we are now. We just started this project a little over a year ago. Now the numbers show that at least 75% of adults with SMI in the US have a smartphone. So we're relying on people's smartphones. They are they're downloading an app to their phone at the time of discharge, like we did in those other studies. This is an app that's a variation of this multimodal intervention called Focus. You see some screenshots here of Focus. It's same paradigm, 3 times a day assessments around these various questions and topics. But then what makes Focus a little bit different, and I think really speaks to some of what Brandon touched on and what we've learned, is that Focus also, and T-Focus and our variation of it, also includes this dashboard. And this is just a little bit of a screenshot of it. What happens is that when people complete their questions through the app, the information then gets funneled to and collated into a dashboard that our aftercare advisors, these masters and PhD level clinicians, can look at and really kind of pay attention to how our participants are doing. In the initial month after discharge, they speak to participants once a week. After that, they have a little bit less frequent calls. But you can see here just an example of the type of information that will be part of a conversation. Our aftercare advisor will call our participant, check in about treatment adherence, any issues, they check in about safety, but then they'll look at this and say, okay, and on the left, you see social, voices, sleep, mood. These are these different variables. Social meaning like social activities, voices like hallucinations, sleep, mood meaning depression. Hey, participant, Wednesday, it looks like you were doing really well, but we see this change. Thursday, it looks like your scores were going down. Friday, not so good. And gosh, I'm looking at, and let you see at the bottom of the screen here. On Friday, you didn't take your medications. What's happening? What's going on? And this really lays the groundwork for us being able to speak to our participants and really more in the moment, not waiting till the next appointment next week or next month, and really figure out what's going on and provide support as best as we can. We also have a community advisory board as part of this project that continues to sort of support our interest in figuring out how best to implement and disseminate our findings. So I'm going to stop there just for the sake of time, but that's kind of it in a nutshell. It's still ongoing, not a lot of results to share, but that's sort of where we're landing at this point and continue to work. So I'm going to turn it back to you, Brandon.
Ethan, I'm just thinking, I'm looking at our time here. In the interest of time, I think it'd be probably good to just open it up for questions and comments, because maybe we can, if some of the clinical application stuff, we can add in about it if it comes up in the discussion. But I think that's probably a good overview of just again, some variety of different programming we've thought of and tested out here, coming at it in different angles. And I would really like to hear any comments or thoughts as to how it might relate to your experiences.
So first, Brandon and Ethan, thank you very much for the terrific, fast-moving presentation of the different things that you're doing over there. We really appreciate it. Alexa, I think we can probably stop the recording now, and then we can have very specific questions that might be relevant for individual circumstances. So let's pause it.